everyone. Thank you guys so much for joining us. We're going to go ahead and kick things off. Dr. Maia McCuiston is our moderator this evening, so we will get started. Maia?
Welcome, everyone. Welcome to ElevateMeD presents Trailblazing for Black Women's Reproductive Health. I am Dr. Maia McCuiston, and I am board member for ElevateMeD. We are here tonight because ElevateMeD is committed to eradicating health disparities. Black women's reproductive health has been a long-standing issue. According to the CDC, which is the Centers for Disease Control, Black women are 3 times more likely to die from a pregnancy-related cause than white women. Multiple factors contribute to these disparities, such as variations in quality health care, underlying chronic health conditions, structural racism, and unconscious bias. Tonight, we will discuss the challenges Black women face getting pregnant and giving birth. Joining us for this important conversation is my dear friend, ElevateMeD's 2024 Trailblazer Award recipient, Chiquita Lockley. She is a producer and director of the critically acclaimed documentary Eggs Over Easy, Black Women and Fertility. She holds a Bachelor of Arts in English from the Spelman College and a Master of Arts in Film Studies from Emory University. Please also welcome Dr. Kelly Burrows. She is an ElevateMeD mentor and award-winning board-certified obstetric gynecologist and an associate partner with Sweetwater Obstetrics and Gynecology. She is also a graduate of the Spelman College, Medical University of South Carolina, and the Houston Methodist Residency in OBGYN. Dr. Louisa Apaya is an alumni of ElevateMeD Scholars Program and based in Philadelphia, Pennsylvania. Dr. Apaya is a second-year resident in obstetrics and gynecology with the Lehigh Valley Health Network, originally from Ghana by way of Chapel Hill, North Carolina. She graduated from UNC Greensboro with a degree in sociology and earned her medical degree from East Carolina University's Brody School of Medicine, and founded the Ghana Heals campaign to meet the needs of the less fortunate in Ghana, West Africa. Dr. Apaya is an inaugural ElevateMeD Scholar and participant in both the 2020 and 2021 ElevateMeD Scholars programs. Welcome, Dr. Apaya. And last but not least, we have Dr. Ericka Gibson, who has been a supporter of the ElevateMeD Scholars program and currently serves on the board for the Medical Association of Atlanta. She is also an obstetrician and gynecologist with the Southeast Permanente Medical Group in Atlanta, Georgia. Another alum of the Spelman College, she received her medical degree from the University of Pennsylvania and completed her residency at the Hospital of the University of Pennsylvania. She also earned a master's degree in public health from the Johns Hopkins Bloomberg School of Public Health. Well, let's jump right in. Ms. Lockley, as a non-medical person, what made you so passionate about developing a product like as monumental as Eggs Over Easy?
First of all, thank you so much for having me. Thank you to all the doctors, the board, the honorees from this past year. Thank you for having me. So Eggs Over Easy. My background in my master's is in film studies. My background, I've been a producer for almost probably like 20 years, and it never occurred to me. I was never interested at all in directing a film. But I went to my gynecological exam to have a pap smear. My doctor, who's wonderful, Black woman doctor, she looked at my chart. She said, Ms. Lockley, you have a birthday coming up. Your eggs are turning 40. What do you want to do with them? 41. Your eggs are turning 41. What do you want to do with them? And I didn't know what she was talking about because what do you do with an egg? I had no idea. And that started my journey of just trying to research and figure out, what does one do with one's eggs? Am I too old to do something with them? Am I still in like the range to do something with them? And if I'm going to do something with them, what exactly am I doing with them? So that was how the project started, with just research. And from that research, I just started learning so much. Fibroids, I knew I had them. My mama has them. Her sisters have them. I'm aware of what fibroids are. Endometriosis, had no idea. Polycystic ovary syndrome, what is that? So there were so many terms that you would think we know about it, since these are the primary reasons that Black women have a hard time sometimes getting pregnant, but I didn't know about them. So my goal was to do a 15-minute short documentary, something I could pay for by myself. And I would do it and just make sure that the girls I mentor, my nieces, that they don't wake up at 41 getting the question of, what do you want to do with your eggs? That's how I started. And I would mention it to like a friend, and my friend would say, oh, you know, our other friend has X, Y, and Z, or talk to my cousin, or, you know, our soror, or, you know, our girl over at Clark Atlanta. I went to Spelman, which you mentioned, but I have a lot of friends who went to Clark Atlanta. So by the time I started just small conversations, talking to this person, that person, my friends, my sorors, I was way past 15 minutes. And there was so much information that it wasn't going to be a 15-minute short. And so I had to go and do a Kickstarter campaign. And with the Kickstarter campaign, my birthday is in October. It's always around homecoming. So I did a Kickstarter that would end during homecoming. And all of my friends rallied and sent out texts, and I don't know what all everybody did, but the note was, don't come to homecoming until you help Quita with this film. So leading into homecoming, a couple days before homecoming, we met the goal of 15,000. And that was just enough to get a trailer so that I could start shopping the film. And for those who are not in the film space, a trailer or a sizzle reel, you want to have like 3 to 5 minutes where you talk about the project, you show clips of what it is you're working on, and then you can take it to a network to try to sell it and get funding to do your whole project. At the time, all of the streamers, all of the networks for television, none of them were interested in a project about Black women's health. They were interested in projects about dancers, singers, entertainers who were Black, basketball players who were Black, but not our health. And so what I thought would be a quick fundraiser, and then it's, you know, we sell it to a network, it was not that. So I ended up calling more friends, trying to find investors, and doing this film piece by piece until we got it done. And then I could take it out on the road and try to pitch it. That was the goal. But guess what happened? COVID. So because COVID hit, we couldn't do very much of that. Everything went online. And because it went online, we started having these Facebook parties. So we would do like, grab your girls, have some lunch, and come meet us to talk about it on Facebook, to talk about the topic of reproductive health on Facebook. And someone who was watching one of our Facebook lunches, I think it was called like brunch and watch TV or something. It had a cute name, like Chat and Chew might have been it. But someone who was watching called and said, hey, can I call my old mentor? Mentor happened to be someone in acquisitions at the Oprah Winfrey Network. So that was part of the story of how we got picked up, and then the rest is history. But the question of, did I set out to start a film, to do a film when I started? Absolutely not. That was nowhere on my to-do list at all whatsoever. I'm happy we made it. I'm glad that it's educational. I was so passionate about it because at first I was in shock, and then I was angry that nobody ever asked me. And I started getting my tests and my AMH and FSH and my AMH, anti-malarial hormone. My AMH numbers were low, not too low to do anything. I still probably could have, but they were so low. And I just wanted to know, like, when did this happen? Because I think I look amazing. I don't look like I should have 90-year-old eggs or AMH that's really, really low. And so then I got mad because I never missed my doctor's appointment. Every year I've been going since I was like 18. I may have missed twice when I was in grad school. Why did it take that long for anybody to tell me? So I had a lot of anger, and I needed to find like a positive way to not be in a rage all the time about it. And that positive path just ended up being a documentary that can help more people in a space where they don't know much about it. And like I said, I went to Spelman undergrad, Emory for grad school, and I thought I knew all the things about my body. I thought I knew, like I knew you as a woman, I come here with all the eggs I'm going to ever have. Some women don't know that. I was aware of that. So I'm thinking I'm ahead of the game, but I was not ahead of the game because I also thought that because I'm in good health, because I have a very regular cycle, even now at my age, that made me think that I had nothing to worry about. So an egg was never even on my mind. And that is why now on this side of it, we're several years out. We're like into the 7th year from when I started the project. I can look and see all the people it's helped. And so I'm very happy that I moved forward with the project.
I am too, as we all are. So, let me ask you this. I'm sorry, Miss Lockley. Let me ask you this. Now that we understand why you are so passionate, and I truly appreciate your journey to positivity, let's explore infertility. So, how do you define infertility?
Okay. So infertility is when you're actively having sex, you're having sex, intercourse, and you're not using any type of protection for a year if you're under 35. If you don't get pregnant in that year when you're having unprotected sex, that is considered infertility. If you're 35 and older, it's not a year, it's 6 months. So some of the women who are in the documentary, they have been going like trying to, not necessarily trying to have a baby, but having unprotected sex for years and never getting pregnant and thanking the stars, their lucky stars that they just were not getting pregnant because the pull-out method was working. But it wasn't that. It was infertility. And a lot of times, especially in our culture, we're excited to get our period every month, like, oh, it missed me. I got my period. And we don't take the time to think something might be wrong because it's not a part of the conversations that we have. It's not our mamas, our aunts. Nobody's having this conversation to say, maybe you're not lucky, maybe it's infertility. And I'm sure some of the physicians can give a better with some better terminology, but in layman's terms, that's what it is. If you're having unprotected sex for a year under 35, 6 months over 35, that is considered infertility and not just like a hallelujah moment.
Okay, thank you. Dr. Pai, could you also elaborate a little bit more on what infertility is?
Yeah, absolutely. So I think Ms. Lockley definitely hit the nail on the head on the general definition of infertility. I think the other thing that I would like to add to this definition is the fact that infertility can be male factor, female factor, or unexplained. And so in our culture, historically, most people think that, oh, if I'm not getting pregnant, it must be one person's fault, the woman or the man. Mostly blame the woman, but it could be half the woman's fault, 40% women's fault. It could be 40% male factor, or it could be unexplained, and we just don't know why you're not getting pregnant, and we need to investigate a little bit further.
Dr. Gibson, anything to add?
No, I mean, I think that those are really comprehensive definitions of, infertility. It's amazing, when I talk to patients and they'll, sort of say the same thing, that they, have been sexually active and not using contraception. Also, I tell patients it's all about timing. So, sexual activity, we really sort of dive in, and what does that mean? Some patients are in long distance relationships and they see their partner 6 times a year. And so, it's really about understanding the frequency of intercourse, having regular cycles or not. Ms. Lockley mentioned PCOS, common cause of infertility. And if I, have a patient who's only getting a period 4 times a year, then that's definitely a different conversation. So, we do a lot of digging when we're talking to our patients around infertility, but I think that they both provided some great definitions of, what we mean when we're talking about infertility.
Dr. Burrows?
I think so far the conversation has been fantastic so far as just giving a general definition of infertility. What I would like to add is that many patients think that trying to get pregnant with the intention of getting pregnant is factored into the definition, meaning, well, we're not really trying to get pregnant, or I'm not tracking my ovulation. So it's not on their radar, as Mrs. Lockley alluded to, that just the fact that you're having regular intercourse, which we usually define as twice weekly, depending on who wants to give the definition of regular intercourse, but twice weekly, you should be able to catch your ovulation period regardless of whether you're really tracking it or not, or regardless of whether you actually have the desire to have a child at that time. So when we speak of infertility, it's not about your emotional connection to trying to get pregnant. It's literally just saying you've been having intercourse on a regular basis. Has it been longer than a year? And if so, then there are some additional questions that we might want to answer about why you have not conceived, because the average person is not going to be that lucky where they just don't get pregnant if they're having unprotected sex on a regular basis.
Yeah, thank you all for that, because there are probably lots of folks who are young and infertile and have no idea and are considering themselves lucky. So thank you all for that. So now that we understand this, let's take a little poll to see how much you've learned about it. So the first question is, what are the primary reasons for infertility in Black women? I'll read the responses. So fibroids, PCOS, endometriosis, adenomyosis, miscarriages.
I just saw that the panelists cannot vote. I was trying to click and I was like, why is it not taking my answer? I was like, I know the answer. Like, I want to answer. That's the spelling.
Nothing's not happening.
86% fibroids, 86% PCOS, endometriosis 62%, adenomyosis 24%, and miscarriages 14%. Good job. So the correct answers are fibroids, PCOS, which is polycystic ovarian syndrome, and endometriosis. The next poll question, true or false? 80% of Black women will develop fibroids by the age of 50. True or false? Pretty good job, everybody. You're absolutely correct. It's true. So let's get back to our conversation. Now that we understand infertility and some of the main causes, Dr. Burrows, let me ask you, when should we, as women, begin to think about our fertility?
So what I generally counsel my patients, and when we start to have that conversation, is typically somewhere between the age of 34 and 35. By textbook definition, typically, and from a reproductive endocrinology standpoint, usually they recommend considering starting to freeze your eggs at 35, but the earlier the better. And the reason is because at the age of 35, that's when we start to have a more increased risk of infertility, abnormal pregnancies, miscarriages, and it's just associated with wisdom that we gain in life as we get just closer to the 40s club. What's happening is that the number of eggs that you were born with, that is the number that you will have your entire life. And so what happens is that number is starting to decrease. And as that number starts to decrease, then the probability of having an abnormal pregnancy starts to increase. And we just know this from historical data. And so as you get closer to the 40s club, that number is only going to naturally start to increase, meaning your risk of abnormal pregnancies, the risk of infertility, the risk of complications. So therefore, definitely at that age, we recommend that patients definitely seek out a consultation, but the earlier the better. If you are in a position at 30 to pursue egg freezing, just to have insurance, as I like to kind of refer to it, then the earlier the better. Typically, unfortunately, the barrier is cost, but usually age 35 is when we really want to start to have that conversation about considering preserving your eggs.
Okay, Dr. Apaya or Dr. Gibson, any additional thoughts?
So I think, Dr. Burrows definitely hit the nail on the head there. Most of the time when we have patients in our clinics, we counsel them at that age, 30, 40, 35, we ask the question, what do you want to do with your eggs, right? But I think in this generation, knowing and understanding that most women are pursuing careers that could, take some time out of their prime years of childbearing. I've started to ask that question a little bit earlier and a little bit sooner, at the end of their 20s. Like, what are your plans for family planning looking forward? In the next 5 years, what does your life look like? Do you want to have a family? Or are you going to be, pursuing your career? And what is your insurance to make sure that once you're ready, you're able to successfully achieve that, and how can I help you in that process? So I think lately, now that we understand the barriers that are around fertility, I've been having that question. I've been asking that question a little bit more readily and a little bit more on the nose than before.
Thank you, Dr. Gibson.
Yeah, and I was just thinking with that question, I'm not aware of, any sort of specific recommendations, like, from our professional organization around, like, there being a set age when we start, asking those questions. I echo Dr. Burrows and Dr. Apia that, around the 34, 35 is when, when we're having these conversations, we're asking more, or I'm asking more pointed questions for, just kind of planning purposes. I ask all of my patients what their intentions are, sort of regardless of age, what their intentions are, for pregnancy, because, sort of especially in, the 20s, early 30s, patients are sort of on the opposite end of the spectrum and they're trying to avoid getting pregnant. They don't want to get pregnant. So we're having, kind of different conversations, but, I think that a lot of sort of what I'm hearing from, Mrs. Lockley and from everyone else on the panel, that really that just sort of awareness of knowing that fertility decreases and that, there is sort of this timing sensitive, nature to ensuring that you have an insurance policy and having it on your radar. I think it's important, to start having those conversations. And I'm definitely getting a lot more patients that are coming in, specifically asking, about, fertility. So I'm seeing an uptick in, patients and even our younger patients being more proactive. So, I'm always kind of addressing intentions for pregnancy, but more pointedly, around fertility, having conversations around fertility around 34, 35.
Okay.
Maia, can I jump in for just a second?
Absolutely.
One of the things in the reproductive advocacy space, particularly with like Resolve, the National Infertility Awareness Organization, and many others, ASRM, that we're also trying to mention in terms of when you should start being aware of fertility is coming out of college. And that's because of the financial implications, which I shared a little bit before the call. If you have the option between two companies, because you're graduating and you're getting a job, male or female, and you can choose company A, which pays you $5,000 more, or company B, which pays you $5,000 less, but includes your egg freezing rider, or infertility rider, or IVF rider, which is easily $60,000, $50,000. You need to know to ask that question coming out of school, because you're weighing your options and you look at the cash amount and you think, oh, this is $5,000 more, but it's actually $55,000 less because they don't include a health benefit that you would need going forward. So in terms of medical, yes, I don't have any comment on that, but practically when you're coming out, to at least be aware of it, because you're leaving $50,000 on the table and making choices that in 3 years or 5 years you're going to regret because you chose a job that doesn't have insurance for stuff that you may need.
I think that's great. Ms. Lockley, can you tell me ASRM, what does that acronym stand for? Let us know.
I think it's American Society of Reproductive Medicine, but that's the overarching arm that there are no rules to IVF and infertility, assisted reproductive technology. There are no rules, but this is kind of a governing body who kind of put some guidelines, because they don't call them rules, put some guidelines in place so that in this country, we're not just not the wild, wild west, but technically they're not rules, they're guidelines.
Yeah, that's, as a pediatrician, I think starting to think about whether or not you want to have a family that young is wonderful. And for those who don't want to as well. So I think that's great. And also, I think it ties into the next question, because whether you can or cannot have a child, if you do so desire, can affect you and your emotional well-being. So my question is now to all of the panelists, how does mental health, from your perspective, tie into fertility and infertility? You can raise your hand, turn off the mic.
Well, I can start. I mean, I think that for patients that experience infertility, there's a definite toll, that happens on, mental health. I mean, I think that patients experience a loss, of control. There's a lot of anxiety. There can be depression around, infertility. I think that within certain communities and, within the Black community, there may be some stigma around infertility and sort of that perception of not being able, to have children. I know seeing patients, there's just, sort of a significant emotional toll, particularly for patients who, get pregnant but experience miscarriage and loss. There can be, post-traumatic stress related to, kind of experiencing pregnancy loss and some of the medical treatments around that. I definitely see, particularly women who experience infertility, that those are some of the mental tolls that infertility takes.
I'll add. So I can definitely speak very transparently about being a physician of infertility and help guiding patients, but then also from a personal standpoint. So I have the privilege of being an obstetrician gynecologist who actually had infertility herself. And so it was a very stressful time for me when I was trying to conceive. I was having difficulty conceiving. I then went through the IVF process. COVID hit, so my one of my transfers was actually delayed. And the entire time, my entire purpose in life is to get up and to help manage women during their pregnancy while secretly dealing with my own trials and tribulations of not being able to conceive. And that was a difficult time because you're trying to remain so positive and optimistic for others. And at the same time, I'm trying to give myself the same pep talk that I am giving to my patients. And so, just it was difficult. And it can just lead to just a lot of emotional turmoil when you want something so bad and it just seems as if it is out of your reach, and it just continues and continues and continues. But I will say that I was very lucky, very, very lucky that 3 years ago I was able to conceive. I now have a 3-year-old at the age of 47, but that's another conversation for another day. Just the journey itself was definitely difficult.
Thank you so much for being so transparent and vulnerable. And congrats
on the 3-year-old.
I was just gonna chime in. As a pediatrician, what I often see, not to take away from conversation of women who and men who have had difficulties conceiving, is that once the child is here, they are very anxious. And I learned a new term, I'm sure everyone knows it now, but a rainbow baby. So once the child is here, they are anxious about everything that this child does. And so they tend to cause themselves even more distress. So they go from one period of anxiety to a second period of anxiety and depression about what could be, what couldn't be. And so all of those things tend to follow them over and over again. I want to open it up to the audience.
I have one thing that I'd
Oh,
like
go
to add.
ahead.
So it was important, and if you've watched the documentary, it was important to include the mental health piece, because a lot of times, in Robin May, she's the therapist who's in the film, but she talks about as Black women, we live life and suffer on isolation island. That's what she terms it, isolation island. Like, you're going through these things in addition to having hormones put into your body, which by many accounts, I've never had IVF, but by many of the accounts from interviews, it's like having your PMS, but it comes more frequently and it's 10 times as hard. So if you think you're going through emotions with regular PMS, this is like up and down swinging. And then you still have to go to work. You still have your community activities. You still go work at the church, all these things. And then you're experiencing all of this on Isolation Island. For a lot of women, they don't tell their employers where they're going. So when they're going to get their shots and all the things that they need to hold this pregnancy together, they're sneaking off work and coming back and just having to deal with all of it. If there are miscarriages in between that, you don't get off days for that. Not in this country, not with most jobs and most insurance. So there are lots of things that are happening while a woman is going through this process, and many times she's not talking about it. So we always say, make sure you have a therapist, or make sure you have a really good group chat with your girls where you're being open and honest about it, because you have to talk to somebody. And we kind of skip over that or glaze over it in our community. So that was why it was so important to put it in the film. One of the biggest statistics came out, it's probably been about a decade now, but that if you are married and you're going through IVF, you have a 300% increase in getting a divorce. So that's also mental health pieces that you have to manage and balance. And once that number came out, I think from looking at what was happening in the reproductive space, we did get more proactive in kind of saying, hey, go advocate for your mental health, because 300% is a big number. People are going to a therapist for regular divorce. This is divorce that is like compounded by or caused by or the side effect of going through IVF treatment. And those numbers just sound awful. They've gotten better. The last few studies I've seen, they've gotten better because people are going to therapy in addition to going for IVF treatments. And then some of the reproductive health centers that you can go through, the clinics that you can go to, they have on-site mental health, like doctors, therapists. So you're not just getting treatment for what's happening physically, but they're also treating the mental health hand in hand. So it's there's like a more of a holistic approach now than when I first started with the project.
We can open it up. Dr. Gibson, did you have anything you wanted to add? Okay, so we can open them up to audience. The first question we have is for Dr. Paya, and it says, Dr. Paya, how do you approach birthing plans with patients to be mindful of their cultural preferences?
I think this is a really great question, especially surrounding this topic. So, funny, interesting enough, this week I've had a lot of patients who have successfully conceived through IVF, IUI, and reproductive technology, and when they come to us in the labor and delivery unit, usually in our health network, we make it a point to have the patient express their preferences of what they want while they're here. So there is like a format for people to express that. But for me personally, as somebody who's providing this care for them while they're here, I like to go through that process with them. And not all of our patients are equal. So some of our patients are of the LGBTQ community, or it's a single mother who is pursuing this journey on their own, and so many other different types of families. So I like to spend some time with the patient and like really talk about, what do you want? How do you expect this process to go for you? And it's simply that building that rapport and having that connection with the patient. Most patients are very open to expressing what they desire, how they want to experience birth with us here, and everybody is very different. So I just like to keep it very open, and also keep it very it's kind of like a working thing, a working relationship with them while they're on the labor floor with us.
Thank you. Okay, I have another one. And this is to anyone. Could you comment on the fertility and other health effects associated with hair relaxers and how to protect women, based on the recent New York Times article? This is for anyone.
I can chime in. I think that there's been, some data kind of linking, relaxers and, hair products, specifically for Black women with, fibroids. I think specifically what I've seen is with fibroids. I mean, we sort of did the poll and shared, really just a large percentage of, Black women and really all women that will develop fibroids over their lifetime. And so, there's a lot of different factors, that would contribute to something that's, that common. So I get this question a lot from patients. I think it's always hard to prove, that sort of hair relaxers or other hair products are a direct link with, fibroids. But I think that there's, some evidence that suggests that, there may be, it may be at play. And so I, will tell people that there may be a link, they can sort of make, decisions about whether they want, to use these products or not. It seems, at least my perception is that there's less use of, hair relaxers, but, there's obviously a lot of other hair products and, just sort of other chemicals and things we're exposed to, and sort of everything we use from soaps and, even the food that we consume. So I always tell people it's hard to kind of tease out that there's this very direct cause, but sort of choosing to eliminate unnecessary, chemicals and sort of leading a healthy lifestyle. And I have a lot of patients that will actually, sort of opt to, do lifestyle management and diet changes, if they have fibroids. And, some of them feel like it does make a difference in like their menstrual bleeding and symptoms. And so, again, I think it's just about encouraging, healthy lifestyle choices.
Thank you.
I'm interested to hear Dr. Burrows, Dr. P, if you guys have any other thoughts or like things that you tell your patients. I may steal them.
There is actually a really good question, specifically about fibroids that I'm going to twist a little bit. The question actually is, how do you know when it's time to seek medical intervention for fibroids? But I kind of want to add a little spin to it. How do you know it's time to seek medical intervention for fibroids as it pertains to fertility as well as in general? So it's a two-part question.
Okay, so just to summarize, we want to know when to seek evaluation for fibroids in general, and then specifically how it relates to infertility. Is that correct?
Not evaluation, but intervention specifically, medical intervention.
Intervention, okay. So in general, for fibroid management, typically we discuss management kind of in 3 phases. So number 1, the most common symptoms that women will experience with fibroids will be bleeding and pain. So those are the 2 most common reasons why someone will come in. That will be their initial concern or their initial complaint. Most women are not aware of the fact that they have fibroids. They are just aware of the fact that they are having prolonged periods, whether the cycles are lasting longer than 7 days. They're having heavy bleeding, meaning that they're having to change their sanitary requirements every 1 to 2 hours. They're getting blood on their clothes. They're feeling tired, weak, fatigued at the end of their cycle. So heavy bleeding. That's the number one usually concern that a patient will bring to the attention of a doctor, or pain. And so it can be pain with your cycle, pain with intercourse, or feeling like pressure in the lower abdominal region. And so patients will come in with that as a complaint or a concern. And then from a workup, then that is typically when we will diagnose fibroids and then have a conversation regarding intervention. Usually the typical evaluation is an ultrasound. Usually a preferred ultrasound is a vaginal ultrasound. And then from there, you talk about management based on the size of the fibroids. And so that's going to really determine whether we can just use like birth control to help with the heavy bleeding and to also help with pain, or are they large enough and are they at a point where they're causing significant impact on the quality of life that we might need to consider other options so far as surgical removal of the fibroids. If you're past fertility, then the conversations are even different. And so there are other options for women who have decided that they have closed that chapter of fertility. Now, when it comes to fertility in general or specifically, then we look at the fibroids and the location of them. That's really important when we are deciding, are we going to remove fibroids? Do we need to remove fibroids? Just because you have them, it doesn't mean that they necessarily need to be removed in order for you to conceive. And so typically we're looking at, does it actually encroach or press onto the uterine lining or to the cavity of the uterus? Because that's where you're going to have implantation, where the fertilized egg is going to attach to the lining of the uterus, and you don't want anything impacting that lining that could potentially increase the risk of miscarriage. So if it looks like the fibroids are in the lining of the uterus, that is a reason to consider intervention. Or if they're significantly large, meaning you do an ultrasound and the uterus is already measuring what we would call equivalent to like a 20-month pregnancy. So when we talk about fibroids, we actually typically talk about it in the size of what a pregnancy would be like. So if your uterus is already at the level of your belly button because of the fibroids, and you haven't even conceived and you're trying to get pregnant, you have to think about, now, maybe the fibroids aren't pushing on the lining of the uterus. Maybe you're going to be able to conceive, but then once you conceive, where is the uterus going to go as it's enlarging in order to accommodate the development of the baby? And so you could have a very difficult and complicated pregnancy, meaning you could have a lot of pain, or the size of the fibroids could actually impact the development of the baby. Or because they're so big, they can increase your risk of bleeding after delivery. And so you have to take that all into account when it comes to the size and if we really need to intervene. But once again, just because you have fibroids, it doesn't mean they have to be removed in order for you to conceive. Everybody has to be individualized and to look at it on a case-to-case basis.
Thank you so much. So we have a next question. This is in 3 parts. So if you guys want to take 1, 2, 3 parts, but I will just ask because it's getting close. If a woman is worried about her ability to get pregnant, what are the first steps she can take? What questions should she ask, and what tests should she have performed?
I can start. I think that the first steps the woman can take is definitely obviously bringing it up to the attention of their OBGYN, that this is kind of where they are. We're always interested in a woman's fertility journey, and where the reason why most of us, chose this profession and specifically to work with women is to be there for each part of their life cycles. So if they're in a phase where they're interested and concerned about their fertility, bringing that up to the doctor, their OBGYN is one of the first steps that they can take. And depending on the woman's age, their other comorbidities, what we already know about the patient or the woman and her fertility journey, that will kind of dictate the kind of care or the recommendations we make moving forward in terms of like what kind of assessments we're going to do and also what kind of testing we would recommend.
The question,
The second part was kind of what questions to
correct.
ask or what things to consider. So, I would ask, sort of what testing their OBGYN is, able to perform and when they would do that testing. So typically we'll do, blood work. We're looking at specific hormone levels, so really kind of ruling out certain medical conditions that could impact ovulation or being able to get pregnant. We may do pelvic imaging, like with an ultrasound or an HSG, which is kind of like a pelvic x-ray to make sure that the uterine cavity and then both of the fallopian tubes are open. Again, we are focusing this conversation around, the woman, but about a third of, cases there's male factor infertility. So we can't forget the partners. And they should really be, kind of willing participants in, kind of the workup because their part is pretty easy. So kind of asking those questions around, what can you do? What are these specific tests? What the follow-up should be, and kind of making sure that they're able to kind of, get good follow-up and sort of understanding of what the next steps are. I would also say that particularly for some of our patients that, may have other medical, conditions or problems like high blood pressure or diabetes, kind of reviewing their medication list with patients. Like I cannot tell you how many times, I'm talking to a patient who's trying to get pregnant and they're on, blood pressure medication or cholesterol medication that are absolute no-nos in pregnancy and they have no idea. So kind of going over medications and just optimizing their general health, prior to getting pregnant.
Thank you. And I think actually, Dr. Gibson, I think you covered it all. I have these questions that I'm going to answer real quickly because I do want to wrap up and give Ms. Lockley time. So I think we covered this early real quickly. It says, for any OBGYN, does ACOG have a stance on when to start checking fertility? And correct me if I'm wrong, but the answer is no. Basically, I think Chiquita talked about, Ms. Lockley talked about it, and the obstetricians and gynecologists, they do not. The last question, it says, what does the literature say about why the percentage of women with fibroids by the age of 50 is higher for Black women than women of other races? That is actually multifactorial, has a lot to do with health disparities and all sorts of other things. So we are short on time. I am going to move to our last question. Thank you all for all of your questions. We're close to the end. I want to turn to Chiquita. Ms. Lockley, with everything that you have learned putting together this documentary and in the 7-year journey after, I must say I am proud to know you and to have been on this journey with you, but what do we do now? How can we change the current dynamics of infertility in Black women?
So that's a loaded question. It's loaded, but I'll give as brief an answer as possible. Ask early. That's what I would tell to every woman, every adult woman who has teen nieces, daughters, mentees. Teach them to have these conversations with their doctors, because a lot of times, if as a patient, if I don't know what to ask, I don't feel comfortable asking things. I didn't know to ask for AMH because I didn't know what it was, and it's a blood test that's going to help me know my fertility, like how fertile I am. If we don't, and not just that, even with like cramps, if you're in the bed with cramps one day a month, that's not normal. But we skip a day out of school from 8th grade up or whatever year through adulthood, we take a day because we have really bad cramps. You may have a different, like an issue, but we don't know. It's so normalized, we don't know to ask. So ask early is what I'll say. It should be the takeaway for everyone. If you've already menopaused out and made it to the other side, God bless you. I'm on my way. But for the ones behind, use your voice and help them. The second thing that I want to make sure we talk about before we end, last week the Senate voted down an IVF bill, which was basically IVF for all, part of the omnibus package that our vice president and some senators put on the floor. Tammy Duckett and a couple other people put on the floor, and it got a no vote last week for IVF, which is not even a partisan issue. So when I've heard it said so many times, like when the nation or the general population, people who are not of color, get the cold, Black women get the flu. So if IVF is a problem for the general population, it's the flu for us. So we have to pay attention to that because that's happening. And it just got a no vote a week ago, not even a week ago, last Thursday. So that would be a takeaway. Pay attention to what's happening around us in where our infertility is concerned. And those are the two that I'll leave you with.
Okay, thank you so much. Finally, what do you all, I'm speaking to the physicians, Doctors Gibson, you can start, then Dr. Maia and Dr. Burrows. What do you all think about the takeaway from this conversation? And then Quita, we can end it off with you.
I think that, Mrs. Lockley definitely highlighted just the importance of having a conversation with your OBGYN. Most of us are supposed to be proactive in having conversations with patients about fertility, but there is an opportunity that we could probably do better. And that physicians need to have the conversations more often and more and definitely more directly. But until we get on board like we should be, patients have to be advocates for themselves. If not, then there might be a missed opportunity for intervention. And so I really do feel like patients should just be very proactive. If you are in your 30s, definitely approaching your mid-30s, then simply just talking to your doctor about your fertility health. And the most important number that you would want to ask for is what's called an anti-Mullerian hormone. That is reflective of your, what we refer to as your ovarian reserve, meaning what's the probability that you have good, healthy eggs that are waiting to be used. And you want that number to be greater than 1. Typically, it'll be between 1 and 4, 1 and 5. So you're not looking for like a 20 or 30, but you're looking for a number that is somewhere between like 1 and 5 is the average. So you want it to be greater than 1. So my takeaway is that I would want women definitely in their mid-30s just to ask for that test. It's a blood test. It's very easy to order, and it will at least give you a baseline of information regarding your fertility health.
Thank you so much. Okay, Dr. Gibson.
These are all such great points and ones that I was going to make. I mean, I think awareness is key. I think Ms. Lockley kind of alluded to, this sort of like black don't crack. And I know, sort of externally, we may not look our age. So it can come as a shock, when, we're trying to get pregnant at 42 and like the ovaries didn't get the memo. So, having those just awareness around fertility, the normal sort of age-related fertility decline, and just options that are available. I think it's hard, just thinking back to my 20s and 30s, really having a true sense of like, okay, I'm going to plan for 15, 20 years from now. But I really like Dr. Burrows', point, and this is something I've been really kind of mulling over for this whole conversation is, making sure that, as an OBGYN, when I'm seeing my patients that, that I'm having more direct conversations, related to fertility. And some people may not be in a space where they're wanting to have that conversation, but maybe it kind of opens the door. They might think about it, or in a couple of years, they may feel more comfortable, kind of coming back and having those conversations. So great conversation. And again, awareness, advocacy. I think that's a huge piece as well. So yeah, I think that all my main points have been echoed already.
Awesome. Dr. Maia.
I completely agree with Dr. Gibson and Dr. Burrows. I think advocacy is where we can definitely tap into next. It's just unfortunate that IVF and fertility preservation is not widely covered or part of a lot of insurance policies. And I think that as young physicians, the new generation that are coming in, we're very vocal about this, and we understand what it means for our generation moving forward. So I think like most of us are very geared up and motivated to step into the political space to advocate more for women, for Black women in general. And so that is my big takeaway from this, is that we just need to get on it and make that happen.
Oh, okay. And to the chief advocate in charge, Ms. Chiquita, how would you wrap it up, and what would you say that you want to be the main takeaway from this conversation in 30 seconds?
For the physicians, and even I noticed that there's some med students on as well. You are probably members of NMA or SNMA. Y'all have conferences every year or every other year or quarterly. If you see a pamphlet or the schedule and it does not have reproductive conversations happening where y'all are in the room saying, we need to ask them earlier. We can't wait till they're 41, because I saw a documentary that said that's a problem. So maybe instead of asking them when they're in their mid-20s, 30s, do you want birth control or what kind do you want? Instead of that being the default, maybe, to Dr. Gibson's point, the question is, do you want to talk about your fertility? Do you want to have an AMH? It's a blood test. It's very quick to do. And I'm never going to be in those rooms because that's not my ministry. God bless the doctors. I'm not going to be in the SNMA or the NMA, none of those panels, but you all are. So if you are there, I said it at the gala, at the dinner, speak up for us, because we're not there and we need for y'all to speak very loudly on our behalf. I always said my doctor is a great doctor. It's not the doctor, it's the system. So if you're in the room with people who can manage the system, who are making these regulations for us, please speak up for us and pay attention.
Thank you all so much. Thank you again for joining us. You can learn more about ElevateMeD, what we do, how we do, and how to get involved at ElevateMeD.org, excuse me. Thank you again. Follow us on Instagram, Facebook, LinkedIn, and Twitter at ElevateMeD Inc. Thank you all so much for joining us. Thank you again for putting up with my technical difficulties, and have a wonderful evening.